All right, Rajani, over to you.
Is Sachit?
Oh, actually, yes, Sachit, if you're there to start.
Good evening, everyone. Welcome to the first of the series of informational seminars being recorded and hosted at the Harvard Mittal and Family South Asia Institute in collaboration with the Lancet Commission on Reimagining Health Systems in India and with the Community Science Alliance in India as well. We are hoping that this will be free discussion between practitioners, initially starting with India and then South Asia, and hopefully with other countries in resource-poor settings, where we can exchange up-to-date information to counter both the widespread misinformation around the management of COVID-19, but also to understand how best to take state-of-the-art science and apply it to the realities of the infrastructure and the personnel that we have access to in our various settings. So without much ado, it is my pleasure to invite Dr. Rajani Bhat, a pulmonologist based in both Bangalore and Delhi. Rajani also knows several hundred million of India's 1.3 billion people, as colleagues and I have recently learned. And so Rajani has invited some of her colleagues here, and we have Dr. Surendar from Brigham and Women's joining us too. So over to you, Dr. Bhat.
Thank you, Sachit. So a very warm welcome to all of our guests in this inaugural session of the Practitioners Workshop on COVID-19 in South Asia. The science and practice of COVID-19 clinical management has been constantly evolving over the last year and a half, and it's been a challenge for practitioners on the ground to keep up with the changing evidence, evolving evidence, as well as for scientists and researchers to continue to receive information from the ground, and that would help them to study different patterns and treatment modalities. So part of the challenge has been just keeping up with the sheer volume of the evidence as it appears and to implement it at the bedside. And clinicians and researchers from around the world have collaborated and shared the local knowledge and emerging patterns of the virus and the disease as it evolves. And to help practitioners parse through this large volume of literature, but sometimes with contradictory conclusions, we are hosting the series of discussions, which we hope will bring clear voices that speak to the evidence, but also speak to how that can be applied and contextualized to settings with limited resources. So our speakers today have a wealth of clinical experience, and they've played a key role in initiatives in their own institutions in generating practical, effective, evidence-based guidelines and protocols. So to that end, today we have Dr. Paul Sonnenthal, who's the Associate Director for Inpatient Medicine and Critical Care at Partners in Health. He's a pulmonary and critical care physician at Brigham and Women's Hospital. And we also have Dr. Richard Gupta, Professor and Head of the Department of Respiratory Medicine at the Christian Medical College Hospital, Vellore. A very warm welcome to our speakers today. And we thank you for taking the time to share with us your insights. As we begin this first part of the series, and today's discussion will be on oxygenation and ventilation at home and in the hospital. We've seen a crisis developing across the world. There's many countries that have been hit with shortages, and COVID-19 has revealed the gaps in healthcare infrastructure in many countries. There's a lot that we can learn from what has passed. The challenge continues to grow in other parts of the world across South Asia, Africa, and South America. So the sessions today, we hope will help will help practitioners in implementing the best of science, keeping in mind resources and learning from other countries. I'd first like to invite Dr. Richard Gupta to share with us her insights and their team's process in developing the guidelines and what they feel was the most effective way of managing oxygenation at home and in the hospital. How have the guidelines evolved? How has the evidence changed and emerged to guide our practices in India and South Asia? So Dr. Richard Gupta.
Um, Thank you, Rajani. And am I audible?
Yes, you are.
Am I audible?
Yes, Dr. Richa. Please proceed.
We might be having some slight connection issues with Dr. Gupta calling in from in region.
Hi. I'm really sorry for the bad connection here. Am I audible now?
Yes, you are. Dr. Gupta, if necessary, feel free to turn off your video. So the most important thing being that we can hear you and your insight.
Yeah, that's right. Sure. So thank you, Rajani, for introducing me to this alliance, as well as giving an opportunity to be part of this panel. Greetings from Christian Medical College, Vellore, India. And yeah, we had lots of patients, and at a point we had around 1,100 patients in the hospital, and it was really difficult, to cope with those numbers. But somehow, yes, now we are at bit ease. So oxygen is probably the commonest drug which is used in care of patients who present with medical emergencies, right from resuscitation to inhalation therapy. Now, when we talk about this COVID pandemic, which ensued in December 2019, and slowly it engulfed the entire world in early 2020, and then the second, third waves, they're still continuing in 2021. The whole world almost came to a still. Everyone looking at scientists, researchers, clinicians, institutes all over the world put their heart and brain as to what could be the best treatment for this infection and how can we save the mankind. Various clinical studies were conducted, and many are underway to study various new as well as repurposed drugs to treat COVID-19. And right now, till date, if we talk about the evidence-based treatment or strategies which are proven beneficial for the favorable clinical outcomes in COVID patients, we have only few on fingers to count with. Oxygen, steroids. Of course, the steroids are not for all the patients. And then there is awake self-positioning or proning, and few others with conditional recommendations like tocilizumab, etc. Now, in the current pandemic, we know how important oxygen has been. It is probably the most essential drug. And it is very important that we know what are the indications for its use, what are the safe practices, and what we should not do. Not very late, with whooping numbers of COVID patients amounting to about 3 to 4 lakh a day in India about a month back. The whole country was crippled with acute shortage of oxygen, leading to untimely deaths of many patients as well. Hence, it becomes very important wherever we are in a small setup or a large setup, that not only do we know when and how should we use oxygen, but also how do we use it judiciously. So for COVID-19 disease, do all patients need oxygen? The clear answer is no. So who are the patients who will need oxygen? And with this comes the important aspect of monitoring. So once diagnosed to have COVID, based on your symptoms, age, comorbidities, and your oxygen level, physician may decide to keep you either in home isolation or in a healthcare facility. So the pulse oximeter, right, a small device, it comes very handy to monitor the oxygen levels. This can be used at home with ease, and I'm sure many of the households will be having one by now. So of the many industries which have flourished during the COVID times, the one making masks and these pulse oximeters certainly be among the top who have flourished. Now, while at home isolation, so we at CMC, what we did was this time in second wave, it became really difficult to cope with the numbers of patients we were getting. So unlike in first wave, what we did was we did admitted patients who were not requiring oxygen. So mild or asymptomatic COVID were actually kept at home isolation, and they were given home isolation packages and the instructions, and a nurse was there who used to call them morning and evening about asking about their well-being. So this package which was given to the patients, it was carrying a home this pulse oximeter as well as the thermometer and few paracetamols. That's what. So while at home isolation, is very important to keep track of your saturation we used to say for about 4 times a day. Now monitoring saturation at every hour is not going to help except for increasing the anxiety and apprehension. It is also important to check the saturation correctly, and single reading of low saturation should not send one in panic. That was the, we used to tell the patients that do not panic if you have just a single reading of low saturation. The saturations should be more than 94% at home. And if it's below this number consistently for some time, then it should be a cause of concern requiring to seek medical advice. Now, what happens? What do we observe? At times, the saturation may be fine. The number may be more than this 94 magic number, but one may not feel very well. So what we used to tell the patients at that point of time in those scenarios was to do some exercise test, check your saturation before exercise and after exercise. And it was a very simple, like 1 minute sit to stand or a 40-step test. So 1 minute sit to stand, we will ask them to sit on a chair, sit and stand on a flat chair for 1 minute, check your saturation before and after. And if post-exercise saturation falls by 3 numbers and below 95%, then we ask them to contact the physicians. For example, if your saturation at rest is 97% before exercise, but on exercise it falls by 3 numbers to 94%, then you should contact the medical facility. Apart from that, what we told the family members and the patient was that it is also to look for any increase in the rate of breathing or use of accessory muscles of respirations, like your nasal flaring or your neck muscles becoming more prominent. So one of the family members was asked to observe when the patient was in home isolation. So these were some of the signs, these were some of the warning signs which used to tell them, patient may be in respiratory distress and you need to contact immediately to the physician. Other warning symptoms, of course, would be feeling of shortness of breath, dyspnea, dizzy, unable to remain awake, etc., which may warrant urgent medical attention. Now, I would like to highlight upon the use of oxygen. Now, we know it is required in certain situations. Particularly in COVID, it's very important that we know when and how we give oxygen. It is prescribed in patients with a saturation less than 92% at rest, or if you have an ABG with if the PaO2 is less than 70 millimeters of mercury, and some people take it a little more conservative, make it as 65 millimeters of mercury. And of course, if the patient is in type 2 respiratory failure, then these SAT levels are the cuts are a little lower, and you tend to give these patients oxygen only when the saturations are lower than 88%. The target saturation with supplemental oxygen remains between 90 to 95%, whereas in COPD, it should be between 88 to 92%. Now, why I'm saying so, there is a robust evidence in the form of meta-analysis which compared the mortality and the morbidity outcomes in acutely ill adult patients who were treated with conservative oxygen therapy. When I say liberal, they aim oxygen saturation to be more than 96%. But the evidence showed that liberal oxygen therapy actually increases the mortality without improving any other, patient-related outcomes. So in other words, supplemental oxygen might become unfavorable if we are aiming saturations above 96%. Hence, we should be very careful, and we should be targeting the saturation between 92 to 95%. Another important thing to consider is what device we should be giving, what delivery device we should be using to give oxygen to the patients, or does one size fits all? Again, the answer is no. There are few low FiO2 devices like nasal cannula and face mask, and there are some high FiO2 devices like Venturi mask, non-rebreather mask, and high flow nasal cannula. With a nasal, if you have to give low flow oxygen, like somewhere in the range of 1 to 4 liters, it can be given with a simple nasal cannula. Maximum you can give up to 5 liters. Now, beyond that, if you want to give oxygen through the nasal cannula, it causes dryness of nose and discomfort. Moreover, we may not be able to deliver high FiO2. Or Hudson mask, which we usually say can be used to deliver oxygen at the rate of, say, about 5 to 10 liters. But it is advisable to use Venturi mask if more oxygen is required, which can actually accurately deliver the high concentration of oxygen according to the flow of oxygen delivered. So with these Venturis, we can deliver oxygen with an FiO2 somewhere between 24 to 60%, with flows varying from 2 to 15 liters. Non-rebreather reservoir bag devices are also traditionally used to deliver high FiO2, or when we require somewhere, say, more than 80%. Now, advantage of these devices is that during expiration, the incoming oxygen is not wasted into that atmosphere, and it is used to fill the reservoir bag from which the patient breathes during the next inspiration. Now, we should use appropriate oxygen delivery device to ascertain adequate oxygenation without wasting oxygen or causing harm to the patient. And in the similar manner, oxygen titration becomes equally important when the patients start improving. You should titrate to the minimal oxygen requirement to maintain the target saturations. We have various sources of oxygen, which may be in cylinders or line supply in hospitals, but oxygen can also be delivered to oxygen concentrators, which operates on electricity, and they are portable devices. So areas where, smaller areas where is that they require recurrent filling, and if that facility is not available, portable devices like concentrators can be used. But at the same time, since electricity is required to produce oxygen from the atmosphere, we have to either back up with the generator, or it should be placed where electricity is available. But mind it, it has a limitation that it can deliver oxygen up to 5 liters, and there are few which can give up to maximum 10 liters, and they cost somewhere around 40,000 to 60,000 in Indian rupees. And last, I would also like to talk about a useful strategy, which is called as awake self-positioning or proning. So basically, proning is the process of, turning a patient from back onto their abdomen or a stomach. So the individual is lying face down. This is medically accepted position to improve the breathing comfort as well as oxygenation. Now, there has been many observational and few retrospective studies in COVID-19 patients, which have found that proning is extremely beneficial in COVID-19 patients with compromised breathing comfort, especially when they are in home isolation. Minded, we do practice in hospitals as well. Now, it is advised when the patient feels difficult in breathing or the saturation decreases below 94%. So at the same time, patient should be able to change the position on his own or with some assistance. Briefly, how do we do it? So we ask the patient to lie down on their tummy for the time, say, ranging from 30 minutes to 2 hours, that is fully prone, followed by a right lateral position for the similar duration, followed by, sitting up at 30 to 60 degrees for the similar duration, then lying on the left side, and then again proning. So this cycle continues. Now, patient should fully understand what he is going to do, and he should cooperate to do the positioning. However, I would like to say, if patient is in respiratory distress, or he's unstable, has altered sensorium, or he has an unstable spine or recent abdominal surgery, or proning will be really contraindicated. Some other situation where this positioning may be difficult will be pregnant ladies in the second or third trimester, or a very obese patient, or patients with some facial injuries and all. So if I want to summarize about the oxygen therapy, some practical points in patients with COVID-19, I would say 4 or 5 or 6 of them. Number one, you monitor the saturations 4 times a day. It's not required more than that to monitor. You should seek medical advice if the saturation falls below 94%, or there is exercise desaturation, as I told. Appropriate oxygen delivery delivery device should be used for the appropriate flow of oxygen. Target saturation when we are supplementing oxygen should be 92 to 95%, not more than that. And for COPD or type 2 failure patients, it should be 88 to 92%. Awake self-positioning or proning is advisable to improve the oxygenation in patients with COVID-19 if they're not able to maintain saturations above the magic number of 94%. And I would also like to say here that we should be prudent and we should be using oxygen judiciously while avoiding any adverse event. So this is all from my side for the moment. And I'm really thankful to the organizers for giving me an opportunity to be part of this forum and share my experience in the what we had managing the patients with the COVID-19. Thank you so much, and I'm open for questions.
Thank you so much, Dr. Richa. That was truly, wonderful to hear your insights and your pointers to practitioners on the ground as to the things that they must keep in mind when they are taking care of patients with COVID-19, especially in the context of patients who are being monitored at home or those receiving oxygen. As we've seen across the world, there have been facilities that are not part of the hospital, but are, for example, COVID treatment facilities which have oxygen delivery devices meant to augment the healthcare infrastructure and make sure that the tertiary care centers are restricted for patients who need more acute attention and need specialized care. I think what I'd like to do is I'd like to go on to ask Dr. Paul Sonnenthal more about those kind of situations where patients need more than just the oxygen delivery devices or need advanced oxygen delivery devices or ventilation. And we've seen this to be a challenge across many countries in the world because these are precious resources. Whether it's ICU beds or it's non-invasive ventilators or it's high flow nasal cannula or invasive ventilation. And it's not just a question of the equipment, but it's also about the trained personnel and using this appropriately. And Dr. Paul Sonnenthal is in the unique position of having the expertise of having set up systems in countries where there are limitations and there's limited resources. And I'd like to invite him to speak to us and share his insights about the challenges in setting up health systems that are robust and where we can implement the best practices. Dr. Paul Sonnenthal.
Thank you so much. And I'll start by saying it's an honor to be here, and I want to thank the Mittal Institute and the Schwath Community Science Alliance for having me here. And I want to applaud Dr. Richa for giving what was a remarkable distillation of the scientific knowledge and recommendations we have for treating patients with COVID. I think, everyone who's watching may not appreciate, but what she just described was, conclusions and consensus and evidence that has developed over the last year and a half and even longer. And I'm very impressed she was able to provide it, because off the top of my head, I don't know if I could be as extensive. But I'd like to talk a little bit about the challenges that come with providing high quality care for patients who are severely ill. And I want to start by framing that discussion by introducing the organization I work for, which is Partners in Health. And Partners in Health is an international nonprofit that is committed to providing a preferential option for healthcare for the poor all over the world. But in particular, we work in about roughly a dozen countries. And we achieve this through a comprehensive approach to health system strengthening. And specifically, we think about we call it the 5 S's. So when you want to develop and strengthen a health system or an intervention or a process, you want to have the staff, the systems, the stuff or equipment, the space, and you also want to have the social support. And what we've seen historically through long-term commitments in various countries, as well as responding to catastrophes such as the Haitian earthquake, cholera, Ebola, now COVID, we've seen that the successful interventions really are comprehensive in that way. So to reframe it, it's a question of how do you take these excellent recommendations that Dr. Risha provided us and bring them to life? Because they're the core and they're the backbone, but how do you do that? And just to give an example is, she spoke a lot about titrating oxygen and making sure you have your goal oxygen saturation. Mm-hmm. And the challenge I have found working with colleagues in Haiti, where I'm at right now, in Malawi, in the United States, is the recognition that these things require constant reassessment. Mm-hmm. Right? It's not a check the box, set it, and then come back, at the end of the shift. It's constant reassessment. And having the staff that allow you to do that, having the systems and training in place, and also the equipment, it really, all of those things are necessary, and no single thing is sufficient to accomplish these goals. And it becomes even more the case when we talk about things like high flow nasal cannula, non-invasive ventilation, and invasive ventilation. So, my sense is, or my experience throughout this pandemic has been, many people have come to me with admirable goals of saying, I'm working on inventing a new ventilator, or I've developed this technique to split ventilators. And while I am deeply appreciative of their commitment to address the COVID pandemic, what I always say is the presence of a ventilator is not the solution, is not the element that will allow you to have mechanical ventilation. What you need staff that are trained to intubate a patient, recognize when they need to be intubated, monitor them. You need supply chain management for consumables. So if you don't have humidification, whether it's through a heat moisture exchanger or an active heater humidifier, patients will develop hemoptysis over time. They will become really uncomfortable. You need fresh tubing. You need sterile water, or you'll get potentially pulmonary infections. We see, aspergillosis potentially coming from contaminated humidification water. And you need, the most important thing, in my opinion, is skilled nursing. I think skilled nursing is hands down the most important thing. And when you don't have all of these things working in harmony, it's a challenge. And that's not my way of saying it's not worth being done and we shouldn't do it. But it's just saying that whether you're in the setting of long-term health system strengthening or responding to a pandemic, to be able to accomplish your goals of providing things like mechanical ventilation, you really do need to think about every single aspect of the care you're providing, or else you run the risk of not helping patients, maybe even harming patients, and spending money ineffectively. So I think that an example to give you is, so Partners in Health, after the Haitian earthquake a little more than a decade ago, in the aftermath, Partners in Health committed to building a hospital in Haiti, where I am at right now. So the response to a catastrophe was build a hospital, develop residency programs, staff the hospital, supply chain, build the health system. And what I can tell you is, at the start of the pandemic, this hospital was the only COVID treatment center in the country for several weeks. And we continue to be the place where people are referred for higher level care. And that's because that's the approach we've taken. And so, I think that's the broad approach to understanding how to provide the more kind of complex, higher level care for sicker patients. There are plenty of specifics and details about techniques and things to keep in mind, which I am happy to get into as we discuss or field questions. But I just wanted to start with kind of that broad framing of the approach that that I take, which is really the approach of Partners in Health, is the kind of is how do we bring to life that expert advice that Dr. Risha just shared.
Dr. Swanantal, could you speak to some of the concerns that people, that practitioners on the field have with the notions earlier on in the pandemic that non-invasive ventilation or high-flow nasal cannula was not to be used, keeping in mind the potential risk to healthcare workers and aerosol enhancing modalities. I wouldn't like to call them aerosol generating, but aerosol enhancing modalities. And how has our practice changed over time? So earlier on, we had this notion that early intubation was the way to go, and then we realized that the wisdom that has stood the test of time still holds true for ARDS with COVID-19. And what would you like to share with practitioners about what the approach should be now in terms of how does one select the modality of advanced ventilation or oxygenation for a patient?
Yeah, that's a fantastic question, and certainly with our knowledge, our approach has changed. And I'll start by sharing a story that from the very first days of the pandemic, when I was working in my hospital in Boston. This was when the United States was in the midst of its first wave, and we did not have COVID tests, but we had patients we presumed had COVID. And I remember I was attending in our ICU, and there was a patient who was ill, and I was discussing with anesthesia, and an anesthesia trainee came up to me and said, "We must intubate now. This is classic for COVID." And I looked at him and I said, "How many cases of COVID have you ever seen? We didn't even have positive tests." And it's this notion that we search for certainty, and in the absence of evidence, anecdote, the plural of anecdote is not evidence, but sometimes we elevate it to evidence. And sometimes fear, and understandable fear, also changes our approach. So initially, I think that we were concerns about aerosolization or aerosol, facilitating procedures, such as high flow and non-invasive. At my hospital, we avoided it. And what that left you was, that left you in a situation where you didn't have a kind of higher level modality to support a patient. And the fear was that you did not want to call for an emergency intubation, because that's the situation where people are exposed. So, and we also saw that patients tended to get worse quickly. So all of that together contributed to this policy, at least in my practice setting, of early intubation. But now we see, with time and kind of evidence and calmer reasoning, that we really don't see an increase in nosocomial infections with proper seal with your non-invasive mask. And I encourage a surgical mask over the high flow nasal cannula. And there is some evidence that doesn't increase CO2 retention. But essentially for me, I use non-invasive and high flow for the same indications that I would for any other respiratory infection or disease. If someone has hypoxemic respiratory failure, and I think that a non-rebreather mask or venturi mask isn't enough, I increase to high flow nasal cannula. If I think there's an element of increased work of breathing, then I will use non-invasive. Or if there are other indications for non-invasive, like COPD or heart failure or immunocompromised patients with hypoxemic respiratory failure. And then intubation, it's the same as now everything we've been doing before. There was a recent meta-analysis that didn't seem to show any benefit from, and admittedly the data are limited, a lot of it's observational, but there's no clear signal that one way or the other is worse. And in the absence of that, let's stick with what we know. So it's, you intubate patients when you otherwise would, although there are considerations in terms of resources and ability to provide appropriate monitoring. One point I will make that is often, I think, confused is that the amount of oxygen a patient will consume actually will go down when you intubate a patient. So I have encountered situations where clinicians understandably say, I don't want to intubate them because I we're short on oxygen and we want to conserve oxygen. And even though intubation and mechanical ventilation is a higher intensity modality, in general, the amount of oxygen you will use decreases for a variety of reasons, but mostly because you have a good seal with the ET tube, hopefully, and you're delivering oxygen straight to the lungs. So that's a really long way of saying, I treat these patients the same way I would treat influenza pneumonia or another type of kind of viral respiratory infection. I hope that answers your question. I'll pause there.
It does. That's very helpful. So I think what was really interesting is that I think in the first wave there were concerns about the safety of healthcare workers. There was also concern about shortage in personal protective equipment, and also we didn't have healthcare workers vaccinated. That still remains a concern for some countries where we've still not achieved vaccination of all essential workers. But your insights are really reassuring in the fact that these are challenges that can be faced with just keeping the same the classic guiding principles of critical care at the bedside in mind. I'd like to come back to Dr. Richa with a question about oxygen use and judicious use of oxygen, something that you brought up as well, Dr. Sonenthal, about how it's paradoxical that what we think sometimes is an excessive use may be something that intubation can help us in conserving that. But Dr. Richa, were there any particular practices in your experience that you found were useful in helping to just be more responsible, whether at an institutional level, at CMC Vellore or in COVID treatment centers? What would be your suggestions and recommendations to people to keep in mind that there are plenty of places where oxygen still remains in short supply? So what would be the best practices that we can follow to minimize any excessive use and just be judicious in our use of oxygen?
Right. So, Rajani, compared to the first wave, which was last year in country, where it was liberally used oxygen, and then over the time we got lots of evidence which suggests that overuse of oxygen is really harmful, in fact. So unlike last time, this time we were very careful, and this time there were the targets were set. And I work in a place where it's pretty much well organized center institute where everything is well in place. So I understand when Dr. Paul said that we need trained people, trained nurses to even titrate or see the things are going right or not. I'm particularly in a place where, yes, I'm fortunate to be here. So one thing is we have to be, as I said, judicious in setting the targets. The targets should be met. It should not be more than that. Then using, if you're requiring more oxygen, then probably using the non-rebreather mask. And it won't, or when the patient comes in, for that matter, I think saturation should be checked in facility of ABG is there. I don't know whether in a resource poor area setting we may not have an ABG, but at least saturation should be guiding us, to give the oxygen. I'll give an example. You have a patient who comes into your casualty or ED and who is gasping. The very common practice, even to the nurses in the ED, is they will put the patient on 100% oxygen with an RBM at 15 liters, 100%, and that's it. They don't even, that is the first thing. If the patient is desaturating, that's the first thing they will put. So I believe, or patient is having, is dyspneic, that's the first thing. So those were the things which we targeted in ED, where we asked them that do not conserve oxygen and titrate oxygen, as not only that we have more number of patients, and we may end up having deficiency in terms of oxygen supply. But at the same time, we need to protect the patient's lungs as well. So at that level, we targeted them, and there were strict instructions, saturation, and check the saturation and accordingly give the minimal oxygen required to keep the patient comfortable, keep the saturations in place. And if we also had set criteria if the patient is requiring oxygen, the respiratory rate is high, is not getting down, then we were actually putting these patients on early NIVs, the CPAPs, or if the things are not working out, then they will go on BiPAP, and that really that does improve the outcomes in the patient. Now, talking about in the places where we really don't have much of the health facility, I think we have to be very conservative. We have to be sure, we have to be checking now and then that like few things could be, there is no leak around. Find patients putting on oxygen, but the cannula is actually out and patient is just, the oxygen is going waste. Masks may be somewhere down, below the nose. So active monitoring, or at least telling the patients if they can themselves monitor. Actually, if you just tell them properly that this is very essential and this is how the things have to be done, especially patients who are well awake, they can practice. Yeah.
So bringing up those points, Dr. Richa, about the vigilance in the emergency department, about titrating up oxygen according to the saturation that the patient comes in with. And I think the other part of it as well, that, especially now with the use of awake proning, this is one of the things that we look out for when patients change positions, whether devices get dislodged. Sometimes having an assigned person in your facility, and that could be a nurse or a nurse's aide, who's doing frequent rounds of the facility. I think it serves two purposes. One is to check if the patients are on the appropriate flow, their saturations are monitored. It also helps us to pick up any change in the patient's clinical status early. So one of the things that came about, as you mentioned, in the first wave, we didn't have a shortage of oxygen, and now we did. So it's also as if the shortage has made us be more vigilant, and that's helped us to even pick up clinical change in condition much faster. So I think that serves two purposes there: looking for leaks, looking for devices that are disconnected, this brings up in so many ways. We've talked about antibiotic stewardship, so now we're looking at oxygen stewardship. We've spoken about steroid stewardship, about the overuse of steroids. And the fact that, and I think that's a topic for another day, another discussion altogether, about only the patients who need oxygen requiring steroids, except a very small group outside of that group of patients. Dr. Sansal, if I may ask you about any other issues that I think, one of the problems that's come up is with also about anticipating the oxygen requirements and the use of concentrators, devices, and what would be your advice to somebody who's setting up a place, maybe, because that's if one is looking at setting up a field facility, a field hospital, and we know that we also have shortage of oxygen. So what would be the ideal devices that one looks at in a situation like this? We know that high flow nasal cannula consumes a lot of oxygen. We know that there are certain modalities that use up a lot of oxygen, but one of the things has also been about the kind of the number of devices that people have been looking at procuring. So sometimes there's these new models of ventilators that one is considering. What if I am a person who's just setting up a facility, what are the things that I should keep in mind when I'm looking at picking up equipment, maybe?
Yeah, I mean, that's a great question, and a very, very kind of broad broad question, but I'll try to do it some justice.
Yeah, maybe just the overarching principles of how I would look at it.
So I think, the first step is thinking about what types of patients you're going to take care of, what type of patients you want to have the capacity to take care of, whether you want to be able to take care of all patients, or you want to have like more of a primary or secondary type of facility where you stabilize and then transfer other patients. I think that's the first step. I think it's very important, and I feel strongly, and I recognize that in many places we're in a crisis situation, but I think that it is always still possible to have an approach to take care of even the sickest patients. And I think it's, I strongly advocate for not kind of saying, we give up on some of the sickest patients. So for about 2/3 of the patients who require admission with COVID, so we're talking 15% of all COVID patients, they'll require oxygen, and they can usually get by with concentrators. The question is, do you have a reliable electricity supply? And you also need to make sure that you're regularly cleaning the filters on the concentrators, and that you're not turning the flow on the concentrators above the recommended amount, because that damages the beds for absorption, and then it also reduces the purity. You can combine concentrators using a Y connector, so that if you have a 10 flow liter max, you can get it up to 20 liters a minute. And that can provide support for someone on a non-rebreather. So you can get by for most patients with concentrators, but concentrators alone are not enough, because one, you need a backup supply. So you need to have some amount of cylinders in case there's an unexpected outage, in case something breaks. You need to have cylinders. And then if you are doing mechanical ventilation or high flow or non-invasive, then you need a higher pressure oxygen source. And so that has to be either really cylinders or wall oxygen from a PSA plant. If you're not doing that, you still need cylinders, because you have to have oxygen for transporting patients. And so this is something that I think often gets lost, is that the reliance on concentrators at primary facilities leads to not having any cylinders. And the absence of a cylinder cuts off a facility from the referral system. Because if you can't transfer a patient with oxygen needs with a cylinder, you basically have nothing to offer a patient other than what's on site. And so I think regardless, if you're going to think about transferring, you need to have cylinders. So that's, and then when you think about ventilators, my preference, so there are some benefits to the kind of LTV transport ventilators in that you can use low pressure oxygen like cylinders. I feel pretty strongly that you want to have a screen where you can see the flow and pressure tracings. It's not absolute, but I think it's pretty important. There are screens you can buy for the LTVs and transport vents, but ideally you have a ventilator that is simple, can do kind of pressure support, assist control in pressure and volume modes, and that it has a screen and it can accept a high pressure or low pressure oxygen source. For me, that's really what you need. And you don't need, these $40,000, $50,000 vents with, special PEEP titration and all this stuff. I'm not an advocate of that. And so if you do that and you rely on concentrators for the people who aren't ill, it is not all that difficult to have cylinders for the few people who may need higher amounts of oxygen. So I believe it's feasible. But again, I want to also acknowledge that I have not, I don't practice in South Asia, and I don't pretend to be an expert on the context. So I say that take it with a grain of salt.
No, thank you. That was really useful information, and it does bear out with the practice on the ground as well in South Asia. We've seen that people have used concentrators. There's actually been an outpouring of support from the international community, and for whenever there's been a shortage of oxygen, There's been supplies of oxygen concentrators that have been channeled into resource-limited settings, also along with oxygen cylinders, as you mentioned. But for the practitioners, it's important to know how to use them well, and your insights were really useful on that. I also like the fact that you mentioned about ventilators, about not needing the absolute high-end ventilators, and also keeping in mind about the limitations of the transport ventilators. One of the things that I find that's really useful is that it matters that the staff is familiar with that ventilator. Sometimes if you have a new piece of equipment that people don't know how to use appropriately, it can't really serve the purpose, because it's, as you mentioned, it's not the ventilator, it's the team that's helping the patient with that ventilator who actually manages to get the good outcome with that in a patient with severe hypoxic respiratory failure. One of the other things that I'd like to address, another question that, again, as we were talking about how the knowledge has evolved from the first wave to the second wave. Again, in the early days, we were avoiding nebulizations for the same reason. Looking at mainly metered-dose inhaler devices for any kind of inhaled medications. But anything else that you would like to, Dr. Richa, would you like to comment about that, about how that, how has that panned out, and how would one, what would be the advice that you'd give now?
Right. So nebulization, yes, as you said, is considered as a aerosol generating procedure, and people are scared of, and it should not be given, is what the advice was. So in the first wave, what we did was there was no nebulization at all in all the wards. It was just MDIs with a spacer. Of time and again, it has proven with various studies that MDI with a spacer is equally effective in delivering the medication as the nebulizer would be. So nebulizer probably was reserved to the patient who were really not able to use the MDI, though MDI can be used with the spacer with the tidal volume technique, where you just you don't have to hold, but you just normally breathe in and out 5 times, and your medication is, at least a portion is in. Also, Rajani, I would like to say, like, when we are talking about the oxygen and things like that, probably one of those method of conserving oxygen would be, there's a usual practice, patient is dyspneic, they give nebulization with oxygen driven nebulization. To conserve, probably we be giving medical air driven nebulization, or as I said, you can have MDI metered-dose inhaler with a spacer, which is equally equivalent in providing the amount of proper deposition of the drug into your airways.
Yeah, that's a very useful tip too. Thank you.
Yeah, but do we have, we still did had concerns about that, but in very sick patients, yes, nebulizer was given. Dr. Paul has any say, and what is his opinion about that? We at our hospital, yes, we were not using nebulizers during this COVID times, especially in this COVID wards.
Yeah, it's a good question, and I pretty much agree with everything you just said, Dr. Risha. We have, at my hospital, we've tried to avoid nebulization if at all possible. I'm of the opinion that if clinically we think a patient really needs it and it'd be harmful for them not to get it, I think it's important to find a way with proper IPC precautions. I will also add, at my hospital, we had an outbreak of about, I think, 70 people started from a patient that was, pre-symptomatic and getting round-the-clock nebulizations. And so and I actually ended up getting COVID in that outbreak. Thankfully, it was quick and I recovered rapidly, but we think it played a role. But there were many, but the reason I bring that up is not because I want to scare people about nebulizations, but in that event, there were many lapses in IPC that allowed it to happen. And so I think the point is that if you adhere to kind of careful IPC protocols and try to minimize unnecessary nebulizations, I think that's fine. Yeah.
All right. Thank you so much. I mean, we're coming close to the end of the hour, and I think the collective wisdom that I've gained from this conversation with the two of you has been that, to some extent, less is more, and to keep the infection prevention control practices robust and strong, and to have greater systems about vigilance and stewardship, so to speak. There's one more aspect that you brought up, Dr. Surendar, which is about when we were talking about resource-limited settings, and you said about, we would like to give the best treatment to every patient. And there's always this part about distributive justice and rationing of treatment. And one of the challenges that we've seen in the Global South is about the use of, or the approach towards figuring out what's non-beneficial treatment and having those difficult conversations about goals of care. And that's really about triaging patients appropriately. And I think one of the consequences of the current crisis that many countries are facing, and this is probably one of the good outcomes that may come out, is a greater discussion about the need to have conversations about goals of care more. And another challenge that some countries faced was a shortage in opioids and sedatives. And I know that's a sensitive issue, but we always need to take care of the fact that, in addition to the oxygen and the modes of ventilation that we offer to a patient, we also offer them relief from breathlessness. So I was just wondering for a quick minute, just, your thoughts, Dr. Richa and Dr. Paul, about these issues, which are also essential to the management of hypoxic respiratory failure, that addressing goals of care, non-beneficial treatment, and the use of palliative care and comfort measures for patients with breathlessness as well.
Dr. Richa, would you like to begin, or I'm happy to begin?
Please start off.
Okay. So I think that's an incredibly important question. And I actually want to slightly broaden the applicability. So you mentioned kind of what to do when we, people know in Brazil in particular that there were shortages of medications that you need to keep people comfortable and sedated on the ventilator or at end of life to keep people comfortable. And I will add that it's not even just about that. It's if you have someone on a ventilator and you don't have experienced and well-staffed nursing, you can't administer these medications even if you have them. And so that's something I've seen a lot, is that, and so I think that it's really hard, and I frankly don't have an answer, but I think that we need to approach these challenges with a lot of humility and acknowledge that, one, we have the capacity to do more harm than good. So I think we have to acknowledge that that's a possibility, because I think that I see a lot of colleagues, not a lot of colleagues, but I know people who say, because we're physicians and we're fighting disease, we're insulated from, these external concerns like, oh, we're running out of medicine. We just keep doing what's medically indicated. And I think that is, I can say that's not the right approach. But I think that, you as hard as it is in the setting of a pandemic, is you need to take a patient-centered approach, and you need to, as best you can, discuss with the patient and try and understand kind of what they, what they want, what they need, what they'd be willing to go through to achieve those goals. And you try and serve them as best as you can, recognizing that, you could put them through considerable discomfort. On the flip side, I will say there are studies looking at mechanical ventilation without sedation, or minimal sedation. But I think it's just so important. I think it's so important not to get burnt out, to become numb, to, lose your sense of humanity. And it's a constant struggle. But I applaud you for bringing it up and asking the question. And I wish I had a more concrete answer, other than I know how not to approach it and I know how I try to frame it. But it's tough.
Well, thank you for that very authentic, from the heart answer. Dr. Richa, would you like to add something to that?
I agree completely with Dr. Paul, and there has been situations. It was not really nice to see those patients being given, how would I say, a whole set of medications, whether useful or not, God knows. I was, though I'm here remotely, I was managing lots of patients back in hometown and North India, and a set prescription of about 15 tablets, 15 medications which will be given. It is a printed thing. It is given to everyone and they have to use it. And one of those medication, Fevipur, which I haven't used it, but I believe it is some 6 or 8 tablets 3 times a day or something like that you have to take. It's I don't know. I mean, it is really, I mean, we have to come up with concrete guidelines, and more than the guidelines which will be there all over, it is how we are disseminating the knowledge among the people, what to use, what not to use to make our patients comfortable. As Dr. Paul said, yes, I mean, it's like, I'll just give you an example. So there's lots of therapies, lots of medications, when the patient is so sick, they wanted to give it. Say, what to do? We have nothing. Let's just try it. No, it doesn't. You don't know the harmful. If you don't know the beneficial effects, can you say that it's not going to harm, right? So that part was taken away. And who is there to audit whether this medication which you have given as a rescue has actually caused the harm, has actually caused the death of the patient, untimely death of the patient. So yes, there should be rationing on everything. There should be dissemination of knowledge, especially in our country, I would say. Sorry to say that, but yes, there should be someone to hold, yes, no, this is not right, this is wrong, you cannot practice that. There shouldn't be any over-the-counter drugs kind of things. Yeah.
Yeah. Thank you so much for both your answers. We have one question from the audience, and I'm just wondering if one of you could address that. It's about, just a moment, I'm going to bring the question up. It's from Mr. Ramesh Verma saying they tried using the UCL Ventura CPAP very efficiently using oxygen with astounding results, and it helps to use the available oxygen for more people. I'm just wondering about if either of you had experience with that, and if you can comment about that.
No, actually, I really don't have any experience at our institute. We don't have UCL devices. Dr. Paul has.
So I have not used it, but I'm familiar with it. So I can say it was developed by a team. I believe it involved at least one person who I know, Tim Baker, who's very smart, very good, very thoughtful. So my understanding is that it can conserve oxygen while delivering CPAP. And it's fairly straightforward and fairly inexpensive. And so I think that, when I've seen devices used in the setting of this pandemic, there's kind of two main aims. One is to kind of improve resource utilization and efficiency and cost, while kind of achieving similar clinical goals that other things would provide, or provide some sort of clinical benefit that's new. My understanding is that this falls into the former, and I know it's been tested rigorously, and so I think it's not something I necessarily can say absolutely we should massively scale it up, and anything we use should, we should try and collect data and understand. But from what I know, among the devices that have been done and produced, this is probably one of the more, has had a process that's more reliable and kind of expert driven. And if I had it, I would be comfortable using it if I thought it was indicated.
Oh, thank you so much. And we're past the hour, and I think and I want to thank both of you, Dr. Richard, Dr. Paul, for spending this past hour with us, sharing your insights and your recommendations for practitioners who are continuing to face the challenge with COVID-19 across the global South. It's been a real pleasure learning from the two of you. And I think you've given us a lot of really practical tips and pointers about how we might be able to serve our patients better. So thank you very much. And with that, I'd like to hand it back to Sachit for closing remarks and to let us know about the next session.
Thank you. Thank you all of you, for an excellent start to this series of lectures with practitioners. We will be making the link to the online repository available so that it can be just, this messaging, of course, for clinicians in India. So we'll make it easily available via mobile devices within the next couple of days. Please check the link that I have dropped in the chat for all of us, where the schedules for the next two panels will be posted very shortly. We hope your colleagues and you can join us. Please feel free to write to us if you have feedback on how these panels can be constructed or topics that you would like to hear about. Thank you kindly. Thank you, everyone.